So coming off of this year's ASCO Annual Meeting 2025, it was like an embarrassment of riches because usually we get 0 to 1 GI abstracts presented in the plenary, where the top 5 abstracts across thousands that were submitted get to be presented. And so again, we were quite lucky, fortunate that there were actually 2 GI abstracts presented at this year's meeting. The one I think with the most profound effect that's even altering how we're treating patients today was the MATTERHORN study. So this was a study of adding durvalumab immunotherapy to standard chemo FLOT in folks with resectable gastric GE junction adenocarcinoma. And so there have been similar trials that have showed that adding immunotherapy in this setting can increase the pathologic response rate, but no studies that had yet shown that it increased time to recurrence. So the primary endpoint of this large phase 3 randomized global study was event-free survival, but also they're looking at things like overall survival and pathologic complete response rate. And of note, they did stratify patients by PD-L1 TAP testing, but they allowed any PD-L1 score to be enrolled in the study. And what they saw is that, quite strikingly, there was an improvement in event-free survival in the group that got durvalumab versus the group that got FLOT with placebo, with a 24-month event-free survival rate of 67 versus 59%, a hazard ratio of 0.71, statistically significant at p less than 0.001. The median event-free survival with durvalumab FLOT wasn't even reached, and it was 32.8 months with placebo FLOT. So quite impressive. And overall survival, not quite ready yet, but there was a similar trend towards improved 24-month overall survival, 76 versus 70%. So the curves separate around 18 months, and then they kind of stay separated. And we await, more overall survival data. Again, there was a higher path complete response rate, 19 versus 7%. And there were added toxicities with durvalumab and immunotherapy toxicities as anticipated, but I would argue that this is now a standard of care with the caveat that we don't have overall survival data yet. And the other caveat such that maybe the group that's PD-L1 0 doesn't derive as much benefit. We don't quite know or see that yet, but that may change how we approach these patients, which has borne out in other large studies in the gastric GE junction space, that when we add immune therapy, it seems to be the group that has to have some degree of PD-L1 expression to derive benefit. But overall, Matterhorn clearly has changed the standard of care, including what we're doing in clinic on a day-to-day basis, now giving D-FLOT as opposed to FLOT alone. The other study that was selected for a plenary presentation was the ATOMIC study. So this is looking at a very important population of mismatch repair deficient stage 3 colorectal cancers after surgery. And we know that this group in the stage 2 realm doesn't really benefit from single agent fluoropyrimidine. In the stage 3 realm, we still treat these patients with standard FOLFOX chemotherapy, even though biologically we know that this group, especially in the metastatic and now in the earlier stage realm, benefits quite exquisitely from immunotherapy. So this was testing the PD-L1 monoclonal antibody atezolizumab in addition to FOLFOX chemotherapy versus FOLFOX alone. Of note, the atezolizumab was given with FOLFOX and for an additional 6 months after completion of FOLFOX versus 6 months of FOLFOX for folks with stage 3 colorectal cancer, 1-to-1 randomization. And quite strikingly, there was an improvement in disease-free survival at 3 years of over 86 versus a little over 76%. And then overall survival is not quite reached, but we await for longer follow-up. So this has also altered the standard of care because it looks like there's a 50% risk reduction, recurrence or death of adding atezolizumab over FOLFOX alone. And again, a relatively manageable safety profile. There was a higher rate of non-febrile neutropenia. So I would argue for folks with stage 3 mismatch repair deficient colorectal cancer that they should be getting FOLFOX with atezolizumab. Now, caveats: do they really need a full year of atezolizumab? Do they really even need the chemo at all? It would have been nice if there was a control arm with atezolizumab alone, but unfortunately we don't have that. So very interesting, and kudos to the alliance for putting on this study and accruing to this specific patient population. And clearly, again, adding immune therapy to chemo is the way to go in the adjuvant setting for these patients. A study that was not a plenary, but I would argue was probably the most important presentation of the whole meeting was the challenge trial. So this was a Canadian trial that was conducted mostly in Canada and a little bit in Australia of looking at exercise intervention following the treatment of with chemotherapy and surgery for stage 2 or 3 colon cancer. And we've known for a long time that exercise is beneficial for this group, but it was an interesting study design such that those patients who had surgery for stage 3 or high risk stage 2 colon cancer, completed adjuvant chemo, and were fit, were randomized to essentially a pamphlet telling them to exercise versus a pamphlet plus a structured exercise program, including an assigned personal trainer and standard meetings, some of which were in person, basically designed to increase their exercise tolerance over a 3-year period. And what was interesting in this was that there was actually a survival benefit. So if you looked at overall survival, it was 90% at 96 months versus 83%, a difference of 7.1%, which was statistically significant. And what was interesting in this group is that it's not because the exercise group got healthier and had better cardiovascular health. It was actually driven by a reduction in the risk of death from colorectal cancer. So this was quite striking. And the question is, how do we use this intervention? We've obviously always been advocating for exercise, but that obviously is not enough. Patients actually need to be linked with a specific exercise program in order to derive benefit. So the question is, how do we generalize this? How do we use it in our clinical space? So we're trying to look at partnering with various exercise and fitness companies to see also if insurance will reimburse for things like personal trainers, because clearly if there's a survival benefit, it actually is more effective than some of the drugs and toxic chemotherapies we use in this setting. So trying to get patients access to this benefit is quite important, which will be more of a health systems issue, I think, moving forward. The top colorectal abstract presented in its session was updated analysis from the Breakwater study. This is a study of combining BRAF targeted therapy with encorafenib, anti-EGFR therapy with cetuximab, and FOLFOX chemotherapy in patients with BRAF V600E mutated metastatic colorectal cancer in the first line setting. This was already FDA approved earlier at the end of 2024, and now we know that there's actually an overall survival benefit based on this updated presentation. The study initially was a 1:1:1 randomization of encorafenib cetuximab versus encorafenib cetuximab plus FOLFOX versus standard of care chemotherapy. The encorafenib cetuximab arm was subsequently dropped, so the main comparison was between encorafenib cetuximab FOLFOX versus standard of care chemotherapy. And we know that there's a progression-free survival benefit, 12.8 versus 7.1 months with a hazard ratio of 0.53, which was statistically significant. What was newly presented was the overall survival data, where the median overall survival of EC FOLFOX was over 30 months compared to 15.1 months with standard care chemotherapy. So a doubling of overall survival in a patient population that we know has a poor prognosis with the BRAF V600E mutation. And what this also showed is that, if you're going to give BRAF targeted therapy, you should really give it in the frontline setting, because even for folks who went on to receive second line and beyond BRAF targeted therapy, they didn't seem to derive as much benefit. Interestingly, in the overall survival, they did see the EC arm that was dropped was somewhere in between EC FOLFOX and standard of care, with a median overall survival of 19.5 months. So not good as good with chemo, but slightly better than standard of care chemo. And we also know that there's a higher response rate with EC FOLFOX, with a objective response rate of almost 66% versus 46% with EC and 37% with standard of care chemo. We do know that adding targeted therapy to chemotherapy does add more toxicity. There were higher rates of GI toxicity and hematologic toxicity with the addition of targeted therapy with chemotherapy. But overall, patients were relatively able to tolerate this without significant discontinuations or dose modifications due to toxicity. So to summarize, EC FOLFOX, I would argue, is now the standard of care for folks with BRAF V600E mutated metastatic colorectal cancer in the first line setting. And most importantly, it means we need to test. So we actually need to know patients not just their MSI status, but their BRAF V600E status prior to any frontline treatment, because this is clearly the superior treatment option for these patients. Last but not least was the Dynamic 3 study out of Australia. The Australians have been far ahead of us on circulating tumor DNA for quite some time, and they continue to impressively design, open, and accrue circulating tumor DNA trials for colorectal cancer quite rapidly. This was a study specifically focused on stage 3 colon cancer with patients fit for at least a fluoropyrimidine in the adjuvant setting, and they used a newer version of their circulating tumor DNA at 5 to 6 weeks post-op, and then clinicians had to pick what standard of care chemo the patients would get. And they were randomized 1-to-1 to a ctDNA informed management strategy versus standard management, which was treatment per clinician's choice and blinded to the ctDNA result. In the informed management arm, patients were escalated their treatment if they were ctDNA positive, and if they were negative, they were de-escalated. And there was a somewhat complicated escalation strategy where if patients were planned not to get chemo, they were given 5-FU capecitabine. If they were planned to give 5-FU capecitabine, they were given 6 months of an oxaliplatin doublet. If they were planned for 3 months of an oxaliplatin doublet, they were given either 6 months of an oxaliplatin doublet or 3 months of FOLFOXIRI. And if they were already planning to get 6 months of an oxaliplatin doublet, they were assigned to get at least 3 months of FOLFOXIRI. So again, it mattered what the treating clinician had selected ahead of time, and the primary endpoint was 2-year recurrence-free survival. And overall, it was a negative study. So actually, the folks who got standard management had a trend towards better recurrence-free survival than the ctDNA-informed arm, but there was no statistical significant difference. The 3-year recurrence-free survival was 48 versus 52% in the standard of management arm. So clearly a little bit lackluster in terms of being able to use ctDNA to escalate therapy. And so part of the concern here is that, maybe escalating in these patients actually doesn't work, and that we actually need to be testing new drugs, not just adding chemotherapy to this group, because maybe it actually doesn't do what we think it's going to do. And there were some post hoc analyses that actually made FOLFOXIRI look worse than FOLFOX/CAPOX, but you have to bear in mind that the FOLFOXIRI group was a higher risk population who were already selected to receive more chemotherapy, not less. So it's difficult to do these types of post hoc analyses in studies that had patients, slightly different risk populations enrolled in different treatment arms. So we hope that ongoing studies like Circulate North America will further support whether it's appropriate to not only escalate, but really, I think the power here is going to be de-escalating, which was not presented in this Australian abstract. Can we get away with giving less or no chemo in the folks who are ctDNA negative? I think ultimately that's where the power of this type of testing and treatment decision-making strategy will arrive.